Have you ever really stopped to think about your own face? I mean, the incredible complexity, the uniqueness of it all. Every little curve, how everything fits together, how it moves, it's you. But what happens when that balance isn't quite right? When it affects not just how you look, but, how things work? Today we're doing a deep dive into something pretty fascinating. The world of orthognathic surgery planning. That's jaw surgery. We're going to explore how experts approach changing the face now. It's moved way beyond just adjusting bones. It's become, well, really holistic and personal.
Oh, absolutely. It's night and day compared to the older methods. Back then, planning was heavily based on, static things, flat 2D X-rays, plaster models of teeth, try and make everyone fit these sort of predetermined averages. But the way it's done now, it's a total game changer. It really embraces how completely unique every single person's face is.
So our mission today is to unpack all of that, how these cutting-edge techniques use 3D imaging, dynamic measurements, measuring things while they move, and even getting you, the patient, involved to get results that are balanced, functional, look good, and are truly unique to you. Okay, so let's unpack this. To really get why the new way is such a big deal, we kind of need to understand what they were leaving behind, right? Traditional planning, you described it like using a flat map for a mountain range. It mostly used those static records like dental molds and those side profile x-rays. What are they called again?
Lateral cephalometric radiographs.
Yeah.
Or cephs for short, yeah. Basically flat side-on pictures of the skull and jaw. Those were the main tools.
And the goals were driven by these things called STOs.
Right, surgical treatment objectives. It was all about hitting specific numbers, specific measurements on that 2D map. Things like selenation A point or A point nation B point, basically measuring relationships between points on the skull and jaws. The aim was to achieve these normal values set by people like Steiner or Ricketts. Clinicians would literally trace the X-ray and compare it to templates of average skulls. It was very number-driven.
So the really interesting thing here is the flaw wasn't the numbers themselves, but what the numbers couldn't show. What was the big miss in that old approach?
Exactly. The single biggest shortcoming was that it just didn't account for how the hard tissues, the bones and the soft tissues, skin, muscle, fat relate to each other, both when resting and when moving. And those relationships, they're actually the most critical part of modern planning for braces and surgery. See, 2D measurements just can't capture that three-dimensional reality, how everything connects and interacts. Plus, sometimes the soft tissue doesn't perfectly mirror the bone underneath. And here's a key thing. Your skeleton mostly stops changing after your teens, but your soft tissues, they keep changing throughout life, aging, Static 2D pictures couldn't predict any of that.
Wow. And the source material uses this really vivid analogy, the Procrustean approach.
Yes, it's a powerful image. Comes from a Greek myth about this innkeeper, Procrustes. He had one bed. If guests were too tall, he chopped off their feet. Too short, stretched them on a rack.
Yep.
Hey, yeah, not exactly hospitable. But it relates directly to those old planning methods. Forcing every patient's 2D analysis into the same normal measurements was like cramming them into Procrustes' single bed. You might hit the normal numbers, but the final result, functionally or aesthetically, often pretty poor because it ignored all that individual variation.
So because of all those limitations, planning today has made this huge shift. It's less about hitting absolute numbers and more about, what did you call it, dentofacial proportionality.
Exactly. Dentofacial proportionality, how the features relate to each other on your specific face. It's all about strategies tailored to the individual, not trying to make everyone fit some abstract average.
Which leads us, naturally, to a whole new way of looking at the patient. It's not just find the problem, fix the problem anymore, is it?
No, it's evolved beyond that. That old problem-oriented approach was useful, sure. Identify issues, solve them. But the realization dawned that focusing only on fixing problems could actually mess up things that were already good about a patient's face.
Huh? Can you give an example? How could fixing one thing cause another issue?
Sure. Okay, say someone has a class 2 malocclusion. Their lower jaw is set back. A common treatment might be to extract some upper premolar teeth to help the bite. Functionally, maybe it helps, but aesthetically, it could flatten the profile, make the face look less convex, which might not be desirable.
Oh.
Or another common surgery is moving the upper jaw forward or upward maxillary advancement or impaction. It can fix certain bite issues, definitely, but an unintended consequence could be widening the base of the nose where the nostrils are.
Right, so it's a real balancing act, knowing what to change and what to leave alone. So what's the main goal now with this modern approach?
The goal now is really about optimization. It's about optimizing the negative things, the things the patient doesn't like or that cause functional problems, while at the same time preserving the features that are already favorable, the things that make their face unique and balanced. We build this sort of optimization-oriented database for each person. Enhance, don't detract.
And when you look at things that might need optimizing, they generally fall into two buckets, right? Function and aesthetics. Let's start with function. What kind of daily struggles can these jaw issues cause?
Functionally, yeah, it can be significant. If your jaws and teeth don't align well, basic stuff like biting into food, chewing properly, that can be really difficult. Even speech can be affected sometimes if the tongue and lips can't get into the right position to make certain sounds clearly.
So beyond just chewing, even talking, what about TMJ issues? The jaw joint itself, is that often linked?
The TMJ link is complex. There might be a slightly higher chance of problems with certain bite issues, but honestly, the increased risk is usually pretty small, often similar to people with totally normal facial proportions. It's not usually the main reason for surgery unless someone has really specific, severe joint symptoms.
Gotcha. And then there's the other big category, aesthetics, which I imagine for a lot of people is a huge factor. How do you even begin to navigate something so personal?
Oh, aesthetics are definitely huge. We usually break it down. Macro aesthetics, that's the overall facial balance, the big picture. Mini aesthetics, things like the lips, the smile itself. And micro aesthetics, the fine details of the teeth. But the absolute key here is communication. Really open-ended talks between the doctor and the patient, understanding your specific concerns, what bothers you, what do you actually like about your face. Then you balance that with, cultural norms, family features, but ultimately you're the one going through the treatment, right? So the risks and benefits of all the options, maybe just braces, maybe braces and surgery, maybe even just camouflage, to hide the issue that has to be discussed thoroughly, your view is critical.
And driving this whole modern way of thinking is this idea called the emerging soft tissue paradigm. Sounds important. What's that about?
It really is. It's a fundamental shift. The real art of surgical orthodontics now is being able to picture the patient's ideal three-dimensional soft tissue outcome first. Like, what should the face actually look like in the end? And then you work backwards. You retro-engineer the changes to the teeth and bones needed to create that specific soft tissue result. It's like sculpting from the outside in, not just moving bones and hoping for the best.
Okay, so if the old way relied on flat, static records, how do you gather the data needed for this soft tissue paradigm? You mentioned a clinical exam, but then lots of detailed 3D stuff.
Exactly. The fundamental idea is that the records we take now need to replicate the functional and aesthetic facial presentation of the patient, how they actually look and move in real life. Static records just can't do that. They can't show you how much tooth shows when someone smiles versus when their face is relaxed, for instance. And frankly, they're less helpful legally if questions come up later because they don't show the whole dynamic picture.
Makes sense. And the sources mentioned three main ways data is collected now. First, there's still the conventional records, right? Photos, those 2D x-rays, models of the teeth, standard stuff, but like you said, missing that 3D element. Then, number two is direct measurement as a biometric tool. This sounds super precise. Systematically measuring soft and hard tissue features using computer databases.
Yeah, this is where we get really specific. Computer programs help streamline it. Pop-up menus for different characteristics, storing data, even flagging measurements that might be outside the norm. And we measure some really crucial things, especially looking at the face from the front dynamically. For instance, filtrum height, that groove between your nose and upper lip. It's not just the length itself, but how it relates to the upper teeth and the corners of the mouth.
Okay, what else?
Then there's the amount of incisor show at rest. How much of your upper front teeth do you see when your lips are just relaxed? This is super important aesthetically, especially because showing less upper tooth is just a natural part of aging. We need to factor that in.
Anticipating the future again. Clever. What about the gummy smile thing?
Right. That's gingival display, how much gum shows above the upper teeth when you smile. Now, interestingly, while surgeons and orthodontists might see even a little as maybe unaesthetic, most people only really notice it if it's quite extreme. And a key insight here is that it's often better not to be too aggressive in reducing gumminess. Why? Because aging naturally makes you show less gum anyway. A slightly gummy smile can actually look more youthful and aesthetic long-term than one where the teeth look too hidden.
Fascinating trade-off. Any others?
One more key one is the smile arc. This is how the curve of the bottom edges of your upper front teeth relates to the curve of your lower lip when you give a nice posed social smile. Ideally, they should be parallel, we call that consonant, We also note if it's flat or even reverse. These qualitative things matter too.
Okay, precise measurements. And the third method you mentioned is digital videography, capturing movement.
Yes. This captures the dynamics, how the jaw moves, the whole process of smiling, even speech. It's particularly invaluable for patients who have an asymmetrical smile. Is the unevenness because of the teeth, the bones? Or is it actually how the lip muscles are moving during the smile? Video helps figure that out, something a static photo just can't show. These videos get reviewed constantly during planning.
Let's make this concrete. The sources have this great case study. A 16-year-old kid, right? His main complaint was a gummy smile, even after he finished his braces. And his orthodontist thought, okay, probably needs major upper jaw surgery.
Exactly. But then came the detailed workup, using all these modern tools. And what did we find? His bite was actually excellent. His profile, overall facial proportions, normal. We measured his philtrum height, 25 millimeter. Commissure height, corners of the mouth, 25 millimeter. How much tooth showed at rest, 2 millimeters. All pretty standard, nothing screaming surgery there.
So where was the gummy part coming from? What did the smile show?
The smile. When he smiled, you saw 100% of his upper front teeth plus 4 millimeters of gum above them. So yes, definitely gummy. And this was the crucial finding, his actual upper incisor teeth had a crown height of only 8 millimeter.
Only 8 millimeter. What's normal?
Normal is usually somewhere between 9 and 12 millimeter. So his teeth were clinically short, and importantly, his smile arc. Perfectly consonant, following his lower lip nicely.
So like detective work, ruling things out. How do they figure out the cause of the gumminess?
Well, based on those measurements, vertical maxillary excess, basically, the upper jaw being too long vertically was ruled out. His facial proportions were normal, his lips met at rest, only 2 millimeters of tooth showed at rest, so not BME. A short philtrum, nope, that was normal too. Lips moving too high when smiling, also ruled out. The aha moment was realizing the primary issue was simply that his teeth were short. The 8 millimeter crown height, that was the reason for the smile.
Oh, no. Not a jaw problem, but a tooth size problem.
Yeah.
So what were the options then? Knowing the real cause.
Yeah.
And what were the potential downsides?
Okay, option 1. The initially suspected maxillary impaction jaw surgery. Yes, it would reduce the gumminess by moving the jaw up, but it would also mean no tooth would show when his face was relaxed, actually. Negative 2 millimeter display. That would make his smile and face look prematurely aged. Big downside.
Okay, what else?
Option 2, orthodontic intrusion. Using braces to push the teeth physically upwards into the bone. Again, it would reduce gumminess, but it would also reduce that ideal 2 millimeter tooth display at rest, and it would flatten out his already perfect consonant smile arc. Solves one problem, creates others.
So the recommended plan.
The recommended optimized treatment was periodontal crown lengthening, a miter gum procedure to expose more of the natural tooth. This would increase the visible crown height, reduce the gumminess, and crucially, it wouldn't decrease his tooth show at rest, and it would keep that lovely consonant smile arc. It fixed the problem without harming the good stuff.
And the family went with that.
They did. And the result was an excellent aesthetic outcome, achieved without any jaw surgery at all. It's just such a powerful example of how careful, precise, dynamic analysis leads to the right, often less invasive, treatment instead of just defaulting to a standard procedure based on norms.
Absolutely brilliant. Okay, so we have all this amazing data, dynamic measurements, video. Now let's talk about the really futuristic part.
Yeah.
Computerized prediction, seeing your future face.
Yeah, this is pretty exciting stuff. It starts by taking that digital cephalometric, tracing the side view map done with the head in a natural position, lips relaxed. Then you overlay a profile photo of your face onto it. They're matched up very carefully.
And then you get to the treatment screen. This sounds like where the magic happens.
Kind of. On the screen, the clinician uses these little digital handles to virtually move sections of bone, the lower jaw, the upper jaw, even groups of teeth. They can simulate things like decompensation, like if your lower teeth are flared out, they can virtually upright them before simulating the jaw advancement to see the maximum possible change. Then, clever software algorithms predict how the soft tissues, your lips, chin, cheeks will likely respond to those bone movements, creating a new predicted profile outline. It's like a virtual dress rehearsal for the surgery.
And the huge benefit here, compared to the old days.
It completely eliminates guesswork during the actual surgery. As the source material points out, it's kind of absurd to be making final aesthetic decisions when the patient is, asleep on the table, draped, paralyzed.
Yeah, not ideal.
Not ideal at all. Instead, every millimeter of movement is planned beforehand based on this simulation. Precision, not estimation.
And crucially, you, the patient, get involved here too, right?
Absolutely. This isn't just for the surgeon. You're right there. The clinician can adjust the amount of change on the screen a little more forward, maybe a little less up until it looks best to you. This opens up really important conversations about, say, family features you want to keep or cultural aesthetics. It ensures the plan respects your unique look, not just optimizing everyone towards some single generic ideal.
That's incredibly empowering for the patient. So how good are these predictions? Are they spot on?
Well, they're not absolutely perfect, and some software is better than others, but they are definitely clinically useful, very helpful. Predictions for the chin are usually quite accurate. The upper lip is reasonably predictable. Lower lip predictions are getting better all the time as the algorithms get smarter and learn from more data. They give everyone involved a really solid visual target to aim for.
So bringing this all home, what does this whole new era of planning really mean for someone considering this kind of surgery?
It means we've traveled a huge distance from that rigid Procrustean bed where everyone had to fit the same mold to this incredibly individualized, three-dimensional, dynamic way of optimizing your face. It's this powerful mix of careful clinical observation, super precise measurements, amazing imaging tech, and maybe most importantly, your active collaboration in the whole process. It's about really seeing you, understanding you, and celebrating your unique features.
So the goal isn't just correction anymore. It's more like harmonizing your unique face, keeping what's already great and just thoughtfully improving what needs it, designing a result that feels completely, authentically you, but optimized.
Exactly, which does raise an interesting question, doesn't it?
Yeah, consider this. As we move further away from these rigid average-based norms towards this highly personalized facial optimization, how might that shift influence how we as a society think about beauty and uniqueness in the future? What stands out to you about that idea?